beyond the obvious. We are delighted to have you back here for our second Tuesday of every month sessions. And for today, we have a very exciting publication that is being discussed. The interview will be conducted by Dr. Amish Vora. Dr. Viraj Lavingia is being interviewed, and following that, Dr. Anant Ramaswamy will do the panel discussion. And finally, we will have the concluding remarks. So I don't need to waste time, or we all know each other. May I request Dr. Amish Vora to please start today's OBTO.
Thank you so much, sir. Can I have my first slide, please? So as the tradition of OBTO goes, we will first shortly describe which paper we are discussing. So today's topic is neoadjuvant immunotherapy in resectable colon cancer. I never thought that I would see this in my career. This is like a sea change which we are witnessing today, and I hope that my thought process is right about that. Can I have the next slide, please? So this is a June 6, 2024. That is exactly 1 month back. This was a publication in New England Journal of Medicine, and by Netherlands group. And the first author is Miriam Chalabi. If you open, just put neoadjuvant immunotherapy in the YouTube, I think, Dr. Chalabi's video is everywhere. And that is a buzzword today in oncology world, which we are seeing. The next slide, please. So I would shortly describe the niche 1 study was initiated before the niche 2 was thought. In niche 1, there were 33 patients were included in the trial for this neoadjuvant immunotherapy, and the eligibility was stage 1, stage 2, and stage 3. All resectable colon cancers were taken. Finally, 32 patients were enrolled in niche study. In 2020, the protocol was amended and there was one more primary endpoint was put. And after that, the niche 2 study was started. Based on the statistical analysis, they said 115 patients are required to see the statistically significant variations. And that's how the niche 2 study started. And the final results were taken, both niche 1 and niche 2 study, which were then. And totally between the two of this, 111 were included in the efficacy analysis. Next slide, please. So why I say seesaw change? 1 dose of ipilimumab, 2 doses of nivolumab, that is, within 14 to 20 weeks, the treatment is over. After that, within 6 weeks, patients will undergo surgery. There was no mention of adjuvant chemotherapy in this particular study design. Next slide, please. Mismatch, all the patients who were included in this study were dMMR or MSI high or deficient mismatch repair gene. And what they had defined, next slide, please. They had defined that there was absence of expression in any one of either MLH1, PMS2, MSH2, and MSH6 proteins is taken as MSI high. This is slightly different from our clinical practice where we take 2 or more loss of expression as MSI high, but this paper had taken any one loss of expression also is to be taken as MSI high. Next slide, please. The pathological response, which was, was a secondary endpoint. It was not the primary endpoint, but it was defined as any patients who does not have more than 50% residual viable disease. It is called as pathological response. Then there was a major pathological response that more than 90% necrosis or less than 10% viable tumor, either in the tumor bed or on the lymph nodes if it is seen. And complete response means there was absolutely 0 viable cells which were there. There were genomic analysis. The whole exome sequencing was done in all of these patients. Next slide, please. So this was the distribution of the patients Next slide, please. As you can see, CT4A and CT4B, close to 66% of patients had CT4A and CT4B. And why I'm stressing on this, because this type of advanced disease, and the next slide, please. If you see, the node positive also was 67% of patients. So we were looking at locally advanced colon cancer who are still resectable, but they will require multimodality treatment, no doubt about that. Next slide, please. And the next slide. Can I have the next slide, please? Yes. So there were basically two primary endpoints. One primary endpoint was safety. 100% of patients could undergo the surgical resection. R0 resection was achieved in 100% of patients. Only 2 patients could not complete the surgery within 6 weeks of completion of treatment, but otherwise 100% of patients had R0 resection. So the safety was established beyond doubt. The second primary endpoint of this study was 3-year event-free or the progression-free survival, which is not mature as yet, and we will discuss that. But here in this slide, if you see, 68% of patients, I would repeat, 68% of patients had 0% residual viable tumor. That means complete pathological response. Next slide, please. I just wanted to add the recent 2023 article, phase 3 trial, neoadjuvant chemotherapy in a resectable colon cancer, including targeted therapy, that was panitumumab. Foxtrot trial had reported 7% response rate in neoadjuvant chemotherapy in dMMR. Please remember this 7% figure and 95% figure because this is important. Next slide, please. This is just the confidence interval chart, if you see. And I was really worried when I saw the trial design of CT4A and CT4B. Next slide, please. As you can see, that there was a least interval there is a very minimal confidence interval, that is 0.5 to 0.75. Highly statistically significant without any error of judgment from the statistician perspective. Next slide, please. So conclusion is for us to decide, but I would say the secondary endpoint, what they have reported, there are 31 out of 111 patients who have completed 36 months, that is the 3 years. Not a single one has progressed. Not a single one has relapsed. That means all the patients who have completed the landmark event of 3 years, 100% of them are relapse free. So this is the paper what we are going to discuss today. Can we close the slides and move to our interview? Okay, so we will start our interview today. And again, it's always more of a pleasure rather than an honor to introduce Dr. Viraj. Dr. Viraj, uh, I think in such a young time, he has made a very big name of himself. Dr. Viraj, very quickly, I'll say, has done MBBS from NHL Ahmedabad. He has done DNB Internal Medicine from Breach Candy Hospital, and he has done DNB Medical Oncology from Apollo Hospital, Hyderabad. But what he has achieved, and I still remember, I think 6 to 7 years back in one of the conference, Dr. Viraj was asking me, okay, sir, I want to do only GI medical oncology. Will I even survive? And I hope, Viraj, you remember in the hotel room, we were sitting and I told Viraj, I said, Viraj, you have done an amazing thing. Please carry on. And today, I think every nook and corner of India, Viraj is getting phone calls from different medical oncologists, including myself, that Viraj, this is the problem in GI oncology, this particular patient, what would you do? Not only that, Viraj has done first in man clinical trial, that is a phase 1A clinical trial recently, where Viraj contributed 4 patients or 6 patients. And I think this is first in human. And this is something at this age Viraj has achieved. In terms of the GI medical oncology, I always feel that he is an encyclopedia. Name any numbers, name any trial, he would first talk about first author and second author as if he has just yesterday met them, and he will give his data so well. Viraj, I must tell you, I must congratulate you in this open forum that what you have done is the way forward, and we are very, very fortunate and lucky that you help so many of us, and you will continue to do that well because of your passion in GI medical oncology. Thank you so much, Viraj, for joining today on this platform for such a wonderful discussion.
Thank you very much, sir. I'm just speechless. That is so much of praise. Thank you.
I think you deserve that, Viraj, and I hope you will continue to deserve that for years to come. Uh, so, Viraj, let's start this discussion. Let's start our interview today. We have 20 to 25 minutes, and we have a lot of things to cover. So, as crisp you can be in your answers, it would help all of us.
Sure.
So, the paper, I would ask you a question that do you think that this paper is a practice changing paper in today's world, that by tomorrow we should change our practice and give all localized colon cancer patients 2 doses of immunotherapy before surgery?
All
Yes or no?
MSI high? Yes.
Only MSI high. Today we are talking of
Yes.
DMMR or MSI high patients.
Yes.
Okay.
In fact, I have already started doing it.
You have already started doing it. Just to add, although little digressing from, based on Foxtrot's trial, have you started giving chemotherapy in pMMR of all resectable colon cancer or no?
So we use it for T4s.
Only for T4.
Especially the right-sided ones, where they encroach the liver or the pancreas, where the surgery would involve multivisceral resection. That is where we use Foxtrot-like strategy.
And T2N1 disease, no.
No.
So N plus does not matter. Multimodality, multivisceral involvement, you are still practicing neoadjuvant chemotherapy.
Yes.
Okay, perfect. Viraj, mismatch repair gene deficiency or DMMR is present in 15% of non-metastatic disease, but only 5% of metastatic disease. Are these biologically different group, or in the evolution of as the disease progresses, you keep losing this MSI high status?
Yeah, very nice question. So this question was raised almost 10 years back, that why in MCRC only 3 to 4% is the prevalence of MSI high. And they had the worst prognosis before the era of immunotherapy. If you see MSI high stage 4 colon cancer compared to the same stage of other colon cancer, pMMR, the prognosis is very bad. So what researchers found that the molecular alterations of MSI high in early tumor vis-a-vis molecular alterations one would find in advanced tumors is different. MSI high in early tumors is excellent prognosis. The immune milieu actually takes care of the tumor and does not allow to escape. But there will be few 3 to 4% who would escape this immune mechanism, and they are the bad ones, the resistant ones, and they comprise the stage 4 MSI high. And that is what we see in clinical practice. Keynote 177, only 40-50% response rates, versus in localized early stages, we see 90+ response rates.
Okay, thank you, Viraj. So I understand that biologically and mutation wise, these two are completely different, and we should treat them in a different way rather than just talking as DMMR stage 1 versus stage 4.
True.
Fine. Viraj, my second question is in Foxtrot, as I showed in my slide also, that there is a 7% response rate in DMMR with neoadjuvant chemotherapy. And we are going to discuss about the response rate, but it is not hidden from anybody.
Right.
Do you ever think it will be ethical for anybody in this world to do a phase 3 trial of neoadjuvant immunotherapy versus neoadjuvant chemotherapy?
Correct. It would. So even the authors concluded in this New England Journal paper that it would be highly unethical once after we knew that for DMMR, the response rate is suboptimal, less than 10%. Even in metastatic disease, if you remember Keynote 177, with the best of bevacizumabs and panitumumab, the response rate was 28% or something, right? So we know they are chemo-resistant tumors, and I don't think so there will be a randomized study of the fashion that you mentioned.
So, Amol Akhade, I don't know whether he's present right now or not. He would not accept. जब तक मुझे phase 3 data दिखाओगे नहीं, तब तक I will not change my practice. I'm just on the joking. Amol has given us that liberty that we can talk about him. But what I'm saying is that
If I can make
if
a
we,
point, Dr. Vamshi made a very good point.
okay,
Chemo plus IO versus IO alone is a very reasonable strategy. And that is what I think. So it's already, the trial is undergoing the COMET study. So yes, but chemo alone versus IO, I don't think so anybody would do this trial.
okay. Going by the papers of rectal cancer and going by the response of these paper, I have my doubts about adding chemo also, basically, although yes, at this point of time when the trials were designed, we didn't know. But if I have to combine colon rectal both together in early stage, I think it will be highly unethical, and we have to, according to me, we may have to change our practice and be satisfied with phase 2 data. That's why I asked this question, that it will be highly unethical to
Yes.
add chemotherapy or compare with chemotherapy. So, Viraj, again, this is a very famous question for OBTO. PAT-CR as the primary endpoint.
That's
Then
the
Dr.
textbook.
Vamshi has asked that question only.
Yeah,
So,
true.
PAT-CR. Secondary endpoint, though, rightly so, and I'm happy that the Netherlands group decided to do that. But like in breast cancer, or if you are the DCGI or FDAs of the world, would you ever allow PAT-CR as the primary endpoint for colon cancer as of today, 2024?
No, so in the contemporary setting, even in rectal cancer, PAT-CR not necessarily correlates with overall survival. But this study is different, that when they published their data, they also gave us about a third of patients, like you mentioned in your opening statement, who had beyond 3 years of survival, and they have no relapse, no chemotherapy given. So this just reassures us that probably this is one setting where one could look into PAT-CR or just major pathological response as a reasonable endpoint for success.
But I was going through the appendix of this paper, and I came across Dr. Patel's NEJM article last year. Adjuvant immunotherapy versus adjuvant alone in melanoma. And what they have found, that people who achieved, almost 31% patients achieved PAT-CR, none of them have progressed. So we have some precedence of PAT-CR, going into in melanoma, at least with IO alone. There was no, of course, melanoma, nobody gives chemotherapy.
I think this is a class effect of a drug, not disease. So if you achieve a PAT-CR or a CCR on immunotherapy, the chance that this patient will relapse in any of the disease is extremely low. I can go further and saying that
so why not acceptable primary endpoint, and we will have thousands of other diseases where we will save patients from chemotherapy. Why are you refusing to accept it as a primary endpoint?
So no, I did agree that this study for this type of strategy, I think it's a reasonable endpoint.
Okay.
But
Right.
the question will come, like Dr. Senthil always says, how many doses you'll give before evaluating? Some just need 2 doses, some will need 6 doses, some will need 9 months. So we don't know that, right?
We don't know that. Correct. Absolutely right. But I feel that going by the data emerging, if we accept PAT-CR as the reasonable primary endpoint, we will have a faster, trial results,
Correct.
and which may help more patients. That is what
As long as they have survival as their secondary endpoint.
Right. Now, the second primary endpoint in this study, let's talk of study design, 2 questions. Second primary endpoint of this study, 2020, and Dr. Ajay Papna has asked, and probably Anant can take this question, dual IO in niche 2, or maybe you can also answer during that time. But the second primary endpoint was 3-year disease-free survival, which was amended in 2020. Viraj, the data is not mature.
Agreed.
Are we even justified in talking further? Or should we say, bas karo yaar, data is not mature?
Correct. So we remember we did OBTO a couple of years back on 12 patients of dostarlimab. And
Correct.
even on 12 patients, this question arises, are we ready to change? and just next month NCCN put it as an option.
Option, correct.
So when the results are staggeringly on your face, when you say 100%, there's no bar beyond that, correct?
Correct.
When you just mentioned in your opening statement, 1/3 of your patients have no relapse, who are all have 3 months follow-up, there's no relapse without chemotherapy. What else do you want? What else do you want? 5 years? You want 5 years?
I agree completely. And
There
right,
are data,
sorry.
building up from MSKCC. They did very nice study in the Lynch patients. We had some Lynch patients in this. Immunotherapy tends to reduce visceral new malignancies as well, right? So you can say, okay, you saved them from this colon cancer. What about the next polyp that is going to come 3 years later? What about the pancreatic cancer that is going to come later? What about the uterine cancer, what's going to come later? So what they found is that the visceral malignancies of patients who took immunotherapy have also dropped down tremendously. So it's like hitting two things at once, right?
No, you are absolutely right. I know I just say that, immunotherapy somehow we'll have to write a different statistics. But as you
Absolutely.
rightly say, if the results are slow, so glaring in the eyes, I think none of us are stupid enough to wait for the data to mature.
Correct.
And just to give PMMR ho ya DMMR ho, the first 2 years, the relapse rate is, almost 25 to 30% of patients relapse in first 2 years. And that's why they had kept 3 years as the cutoff of the disease-free survival that was there. That is, rightly so. So none of those 31 patients who have crossed 3 years have relapsed. I think this is very, very important. Now, second question on study design, Viraj. This troubles me a lot. Now we have the results. So in the hindsight, the answer is there.
Correct.
But would anybody ever have designed a trial where T4A and T4B, you don't plan adjuvant chemotherapy?
Yeah.
And 67% had not. Which of us today or even yesterday see T4N plus disease may, we will not think of giving adjuvant. And in the study design, there is no mention.
Correct. So they left it very open-ended. They left it for the physician's discretion. And I agree, I would be very skeptical in not giving adjuvant Kpox or FOLFOX. In fact, there was a similar study which was presented in this year's ASCO that was from East with the sintilimab, another monoclonal antibody with a CTLA. And in that, again, the same results they found, staggering pathological responses. But in that, physicians, about 40% of cases, they did use adjuvant chemotherapy. Now, so the discussant said that why was it even needed? But, it's like it is an open-ended thing. And till we know more, you would tend to give at least 3 months of doublet chemotherapy to node positive patients.
Absolutely right. Because this was something which I would have not probably approved. In the hindsight, if you see, especially T4N plus disease without any adjuvant chemotherapy, a very, very bold move which paid off. And probably rightly so, because sintilimab and the rectal cancers, and there are a lot of these things. My next question is on the pathological response. And Viraj, you are the master of immunotherapy. I want to ask, where does this 90% come from? Major pathological response. Where, yesterday I was talking to Anant and we both realized that when the osteogenic sarcoma started, 90% was the first one.
Yeah.
Then they found 99% is better than the 90% and they changed the thing. So is this 90% arbitrarily or is there any scientific rationale?
Like in anything in medicine, everything is arbitrary. Even p-value of 0.05 is an arbitrary cutoff, right?
Sudeep, if he's there, he will kill you on this, huh?
No, it's published. It's not my opinion. So the statistics itself is your assumption, right? So it's an arbitrary, and even the TRG grading that we see in rectal cancer. So they try to mimic the TRG of the rectal cancer, but I agree with you. It's an arbitrary number. So a person with a 70% response versus 95% response, they all are having same survival.
Yeah, because this will be very important, as Viraj, we were discussing yesterday that immunotherapy, as we have seen in rectal cancer, as the time advances, there you see more and more complete responses. So
Right.
to label it as 90%, I feel it's very, very arbitrarily, and we will have much better refined versions of these definitions as the time come. That's
That's
why I thought I'll ask you this question.
true.
Viraj, my next question is about the genomic analysis. This particular paper talks about MSI high in two broad categories. One is Lynch syndrome and second is non-Lynch syndrome. In non-Lynch also, they say MLH1 hypermethylation cohort and second cohort of somatic. Dr. Amish Vora, who works, in separately independent in private, and people like me, tomorrow when I have DMMR, do I need to go into the detail of what type of MSI high is there to change my practice, or this is more of a research question?
So short answer, it's a research question. And I understand why did they do this. If you see MSI high in non-colorectal, where the epigenomic changes is not much, there was a hypothesis that immunotherapy tends to work more with in the Lynch variant of MSI high and not the sporadic variant, which were not methylated. That means there were mutations in one of the genes. So in this paper, they wanted to fulfill that hypothesis that do we see any differential response? And there was no differential response. If your MSI high in any ways, you had the same result. So short answer is no. If you have MSI high, take it as MSI high.
So while we are talking on that, the definition of MSI high, we in every conference in last 3 years, we always say 2 or more loss of expression.
Yeah.
But this paper has defined as 1 or more loss of expression. Viraj, what is correct? Am I right? Suppose tomorrow I get only PMS2 as the loss of expression. Based on this paper, I am justified in giving a doublet IO.
Yeah.
What is the right answer?
So the right answer is 1 or more is correct. The problem with that is there is a caveat. If you have a PMS2 as a solitary loss, it often is a lab error also, because that being a very labile protein, it often gets lost. Even with the best of Ventana clone, this can happen. So what we do is, if you have a solitary loss, we often tend to check it with a PCR, and we all have mixed results, right? The PMS2 can be the true MSI high, or PMS2 loss can be just lab error, and the PCR would show all stable. So the take-home message should be, if you have 2, you don't need to confirm it. But if you have 1, you're better off confirming, because then you would burn your fingers.
Would burn your fingers. And I can tell from my personal experience that I have burnt my fingers only on IHC at least more than 3 to 4 times. And it is always better to double check on PCR, especially if you have 1. Although I have treated based only on 1 also, and I have got desired results of IO, but I have, on the other side, I have burned my fingers. So immunohistochemistry, how well the lab is doing, how well the platform
What
is being
clone they are
used,
using, yeah.
what tools they are using is very, very important. So there is no harm in confirming with PCR for next 1-2 years at least, till we have all the labs they know, do properly MSI high. Viraj, next 2 to 3 minutes, I do not want to interrupt you, and I want to hear the results of this trial from Dr. Viraj Lavingia's analysis.
So you want
The results, the efficacy of this trial.
So the one which you already showed,
I showed, but how do you interpret the efficacy of this trial?
So, I'm taking the words of Vinay Prasad, whom I regard very high. These are one type of studies in oncology where we can put an analogy of parachute study. You know, parachute in oncology have been claimed by many other studies, but this is one which is high up, even as high as imatinib for CML. We have not seen anything like this immunotherapy for colorectal cancer, at least in early stage. There is nothing like this we have seen in oncology where you say 100%. Mind you, it's not 90%, it's 100%. And so it is practice changing. And just a corollary to that, in rectal cancer 2 years back, we were talking about 12 patients. This year, Dr. Sarsek showed 48 patients. Again, 42 out of them who have at least 6 months follow-up They're all in complete response, no relapse whatsoever. So we don't need a randomized trial to prove whether you need a parachute to jump out from an aeroplane. It's the same, analogy for such a strategy. If you have MSI high colorectal cancer, you should give immunotherapy. I would go one step further, and I'm sure researchers are doing that. Then why at all offer them surgery? If you're so sure with
So
your
I'm coming to that, stop your thought there so that you can answer it better. In this particular paper, the complete pathological response rate was not correlating with radiological response
correct,
at all. I think only 7 patients had, or 7% of patient had
two,
radiological
yeah,
complete response as compared to, the more than 90%, 95%.
yeah.
So my question is that before you go on to why surgery at all, first answer this question: why there was no correlation between radiology and pathology in this particular trial?
So there are multiple reasons for that. First is that we did imaging in this study at 6 weeks.
Right.
That is when we know biologically also that the T cells are attacking the tumor. And even though there is no tumor, you would still see the bulk there. So like you said, 75 patients out of 115 had path CR, that means zero tumor, and only 3 out of them had shown a CCR. That means radiology concordance with pathology is not good because we are doing it early, point one. Point two, this is, we know, even in Sursex data, she showed this year that out of 42 patients, only 8 patients showed CCR at 3 months. Only 20 patients showed CCR at 6 months, and remaining 12 patients showed CCR at 9 months, although they gave only 6 months. So you see, this is like a radiation effect, radiotherapy effect. You don't see a CCR in 1 month after radiotherapy, right? We wait long. As long as they are shrinking, you are good to wait, right? So that's why it's not wise to see the result at 6 weeks and decide CCR or no CCR.
Okay.
Correct.
Vamshi has, can we
Yeah.
accept
Yeah,
this?
I want to make a comment on that.
Yes,
This
please
is,
go
in
ahead.
fact, the most important critique I have of this paper is that, I don't want to give immunotherapy to T3N0. Okay. I know T3N0 resection has 95% survival, right? Uh, Immunotherapy is not without side effects, although in this study there were no mortality, but we know there are grade 5 toxicities, especially with dual checkpoint blockade. And it can happen with one dose also. I recently had a one dose myocarditis. I'm still in the shock from that patient. So a T3N0, how confident is your radiology to tell you that this is a T3N0 vis-a-vis T3N1? And that is the only critique of this paper, that we are relying to take those high-risk patients into this study while we can give unnecessarily. So you said 66% were stage 3, right? So that means almost around 15 to 20% were T3N0s who don't require anything apart from surgery. So it is on us that how do we delineate those stage and not offer them additional treatment.
Viraj, in colon cancer, it always troubles me when the PET CT does not show any lymph nodes and then you get the lymph nodes in the pathology specimen. I think, according to me, this is a very bold statement. You are right. Theoretically, you are right, Viraj. But T3N0, clinical T3N0, many a times turns out to be N plus when the
Correct.
specimen is, this thing. So many times I have seen localized perforation in the specimens. And if you see 2020, when they amended, they included only T4N plus disease in the study. So the authors also thought that, okay, probably these are the patients who are going to require. But my question is that you did still didn't answer that, why no surgery at all? You were going, and then I stopped you for radiological and pathological response. Do we ever will see a day when T4N plus disease, localized colon, treat only with immunotherapy, no surgery, nothing?
100%.
100%. Oh, that's
Not
amazing.
today. Not today.
Not today. Okay. But assuming you have given 2 doses and if you see the radiological complete response, if somebody close to you, would you give immunotherapy alone and wait?
So there are multiple questions. How long and mono or dual? We know dual is better than mono in stage 4 MSI high colorectal cancer, like 90W, 8 HW just showed that you have better PFS and better durability, less PDs, like we saw in Keynote 177. We don't see that in 8W because
Correct.
of the ipilimumab. But we don't know whether giving dual is important in early stage, because early stage MSI high, they are good prognosis, and you may get away by just doing a PD1 PDL1 strategy. You don't need CTLA4. So we have two unanswered questions. Until that, we cannot be sure, but I'm like 100% sure we are getting these two answers, that how many doses we need and do we need one or two drug.
Right. So my last question to you is lot of sort of we are summarizing this. Okay. So tomorrow in the OPD, if I have a localized colon cancer, which is easily resectable, but turns out to be dMMR, I give 1 dose of ipilimumab and I give 2 doses of nivolumab 14 days apart. After that, I request the surgeon to do surgery within 6 weeks if there is no grade 3 or grade 4 toxicity of immunotherapy. And if there is a complete pathological response, I do not give adjuvant chemotherapy. Am I scientifically right? Am I ethically right? Or am I legally right if I start practicing Nick from tomorrow?
So legally, no, because it's still not part of the guidelines, right? So you would still end up giving chemotherapy if your node was positive in preoperative scan. I'm not aware that NCCN has endorsed this strategy full on, but we are not
Not till yesterday.
yeah. So, but we are not very far away, right?
We are not very far away. So would it is endorsed, Dr. Ajay Bapna has written, it is
It is
endorsed in
mentioned.
NCC.
It is mentioned as an option.
So if it is as an option, I can exercise that option. Because like you, I have after this paper, I have offered immunotherapy to 2 of my OPD patients. And I think so. Important point is again. So Viraj, is this a practice changing paper from tomorrow?
Yes, but point is whether mono or dual, and why I bring this up is there is another study called Neoprism from UK. They used only 3 doses of pembro before surgery, and they have similar sort of major pathological response, right? So the question arises: do you need to add your CTLA4? Do you need to give 2 doses of Evo or 3 doses of pembro? We are just talking.
Viraj, last question. Again, I'm asking 3 times. Is this practice changing paper according to you?
Yes, we
It
are
is.
we are doing.
Unequivocal, but with some caveats. And since Parikh sir has appeared on the screen, I think this is our time. And I am also exhausted of all my questions. I think, according to me, this is a practice-changing paper. I don't think I will wait for NCCN guidelines to endorse because those are the guidelines. As long as there is an option in the guidelines, I would like to exercise this in especially T4N plus disease. This is what I get from you also, and this is what I would practice for myself. Now, let's see what Anant says about this or what he extracts out of our panelist. Viraj, thank you so much for answering so succinctly everything. And I would request Parikh sir to take this forward. Viraj, you have to stay. You are one of the panelists.
Thank you, sir.
Thank you very much, Amish and Viraj. That was really an exciting discussion. Um, everybody seems to agree that it's practice changing. Viraj also mentioned that very soon the need for surgery might totally disappear. I just want to make one clarification about the legal requirements. While everybody thinks that NCCN is a legal requirement, it's definitely not so, especially for India. And as far as the law is concerned, if you have a scientific basis for whatever decision you have taken, that is legally acceptable. So I don't think we should worry ever whether it is in NCCN or not, even though several judgments quote NCCN guidelines as supporting their decisions. Anyway, let's come back to the important publication. There has been such a flurry of comments and questions on the chat box that the panelists are raring to go, and I don't want to stand between them and Anant Ramaswamy. So it is my honor to introduce Dr. Anant Ramaswamy. He is a senior medical oncologist with special interest in GI malignancies and is a dear friend from Tata Memorial Hospital. Over to you, Anant, and you can, take the panel discussions further.
Thanks, sir, and thank you for letting me be part of this. So can I share my screen, please? Is it possible?
Yeah. Yes, sir, you can do that.
Yeah.
So while he's sharing, can we have the panelist names?
Yes. So it's my pleasure and honor to welcome Nilesh sir, Bapna sir, Shrivanti madam, Dr. Rajkumar, Dr. Vamshi, Shraddha, as well as Viraj to this panel. Are all of you there? I hope all of you are there. So I think the stage is set with that really vivid discussion by Amish sir and Viraj. They've covered most of the points. So what I'll do is I'll look for your perspectives because the data is out there. I just want to know what you think of it. That's one. And I had taken Amish sir's permission yesterday to add rectal cancers also in this, because I have such a good panel and you can offer your opinions on that. So these are the couple of things that I'll discuss over the next some time. So I'll probably start with Nilesh sir. All colorectal cancers, do you test them for MSI, irrespective of stage, and what method do you use?
So yes, I test all my patients for MSI, and the stage would matter in the sense that if it's a metastatic colorectal cancer, then it will not just be an MSI, but it will at least be a MSI, KRAS, NRAS, and a BRAF, and other mutations also as a part of an NGS panel. In early stage, not upfront, but post-surgery, yes. And in fact, as I was going through this article, that was the first thing that came to my mind, that how often do these patients first present to a medical oncologist? It's a different scenario in a hospital where you have an MDT handling these patients, but otherwise, most of these patients are seen primarily by a surgeon, and therefore, the initial biopsy may not be the ideal opportunity where this gets done. But should I have the opportunity, I will definitely do it at that time. And in an adjuvant setting, I would probably do the MSI, KRAS, NRAS, and BRAF, the additional BRAF also, because in case the patient is MSI positive, that helps us understand whether it's a Lynch or a non-Lynch situation. I am comfortable doing the immunohistochemistry method, but if I'm doing the complete panel, then it'll be a part of NGS. I think in the setting of a neoadjuvant situation, probably the IHC would be a better test, primarily because you'll get the reports within 3 to 5 days, as opposed to an NGS that takes approximately 2 weeks for the reports to come in. And I do not reconfirm an IHC report unless, as mentioned earlier, it is a single marker that is not marking. And in that case, generally, I have a discussion with the molecular biologist and take it forward for an MSI by the NGS method.
That's fairly comprehensive. I'll take one more opinion on that. Bapna sir, in your practice, do you do MSI for all colorectal cancers? And do you ever cross-check? Is there any situation you cross-check?
In the early colon cancer, when the tumor is PT3 N0, then in all these patients, we are checking the MSI. And since we are in our learning curve for the IHC of doing this test, we are most often sending them for PCR so that to avoid the inter-observer variability. And, there is a more validation than the IHC. But as the time goes by, we will also rely more upon MMR, because as Dr. Nileshwar said, that if you do within your hospital, the results come within 2 to 3 days.
Fair enough. I think we often forget that PCR is still considered the gold standard, but I think we are getting there in terms of IHC, being this one. Right. And this is just this multiple data sets would say that IHC, PCR, there's very good correlation. PCR, NGS also, there is very good correlation. But one thing that even I do is that if there's an isolated loss, technically it's possible that, even a PMS2 loss is still MSI high or deficient MMR, but I would like to cross-check. And that's primarily because the stakes are so high. I'm going to use a therapeutic option which is expensive, so I want to be sure. Fair enough. I just wanted to bring in the Foxtrot study, which was the other major study of neoadjuvant therapy in colon cancers. This is some of the harder endpoints of the study. And Dr. Shevanti, you have T4N2 disease, let's say right-sided cancer. How convinced are you? And let's say for discussion purposes, this is a proficient MMR tumor, T4N2 disease. How convinced are you on Foxtrot? Or would you still say, no, let's just do surgery?
So for me, if I've still not moved on completely to Foxtrot, if there is a tumor that is resectable, does not involve significant organ loss. By that I mean adherent tumors, tumors that are very, very high risk, and of course MSI stable. Those are the tumors where I may think Foxtrot didn't come to me as first reflex.
I'm sorry, but can everyone else mute, please? I think ma'am's getting interrupted. Thank you. Yeah, please go on.
So basically, only in a very obvious case do I utilize the neoadjuvant approach. I haven't been very easy to utilize Foxtrot regimen, mainly for the reason that if there is a patient that requires a very extensive surgery and is completely defined be MSI stable, that's the patient that I may
Fair enough.
Other than that, I would.
Yeah.
So high risk to major
the thinking
MSI
a lot of us
stable.
would have, that the data is there, they achieved their primary outcome. I'll take one more opinion on that. Dr. Rajkumar, what is your candidate for neoadjuvant?
I agree with Dr. Seventh. It's very difficult and in a practical way, it's very difficult to sell the neoadjuvant strategy in a colon cancer for a GI surgeon, whether it's an oncologist, surgical oncologist, or a SG fellow. Why? Because the colon cancer surgeries are evolved in a fantastic way and they are doing extremely good with the laparoscopic, robotic, everything. And it's very difficult to sell unless otherwise I'm going to achieve a less morbid surgeries or less technically a challenging one. But colon surgeries have evolved so much, and to sell these off, these neoadjuvant concept of leave alone chemotherapy, even immunotherapy to a highly resectable subset of individual is little difficult. It has to mature, and I have to show some survival data of 3 years of duration. It's a long way to go to sell these off to the surgical colleague. I may differ with the speaker, but it takes a little longer time. Unlike a rectal cancer where the multidisciplinary approach are evolved fantastically, colon cancer is still the surgeries are doing fantastic, but unless I have a very robust data with the 3-year survivals of the tuning, and
or maybe the surgeon is not convinced of doing an R0, then he'll send it to you. Maybe. That
is very minor subset of patients.
Yeah. Also, the other thing I'd like to point out in the Foxtrot is that we don't see R1 resections in colon cancers in the current era. I can't remember the last time I saw an R1 resection. And here they had 11% R1 resection in the upfront surgery arm. That's unacceptably high to me. And, maybe, neoadjuvant was kind of just compensating for not great surgery, So yeah, Amish sir, please.
No, Anant, can I just make a point? See,
Yeah.
two things here. We don't have any new robotic or any laparoscopy showing a survival advantage. So,
Sure.
I mean, that's one thing to be noted. There's a trial was negative. The robotic trial was negative for colon. Secondly, again, we come to the same issue of the radiology. You have an extensive disease, large disease, that's the patient where I would actually suspect peritoneal disease. And I would be more comfortable sending that patient for a surgery. They may just open and find peritoneal mets, and that's not an unusual problem. So again, the radiology matters here, and I think we still don't have the good radiology.
Yeah. I'll come to the radiology, Dr. Amshi. I was just trying to see how many people are kind of convinced by Foxtrot. We are not, and most people aren't using that at least. Yeah. So there, I kind of have agreement there, and definitely
Anant, sorry, I wanted to make a point here about the R1 resection. Okay, I take a corollary of ovarian cancer when compared to the Western literature, we have very less R1 and we have many of the R0 resection. Either our surgeons are doing it better or, our definition of R1 is little loose. But I feel what Vamshi has said makes a very huge good point that many of these mesenteric thickening and peritoneal thickening which you see on the PET scan, later on when you do in retrospect, turns out to be the disease rather than anything else. So I just wanted to say that Foxtrot had 11% R1 resection. In T4N plus disease, it is not that easy to have R0 resection.
Okay, I will agree to disagree on that.
So I think
Anant, even I would like to make a point.
T4B,
Yeah, Shraddha.
T4B probably.
Yeah, I mean, I don't think it is about how extensive a resection you want to do. I mean, the more extensive you do, you're likely to get an R0. So it's like if I add a coloviple to something, I'm likely to get. So probably you need to see why the R1 resection rates were high, because they probably required a morbid multivisceral resection, and
possibly
they left it at that.
Yeah, fair enough. It's just that I was going over our database, and I think last 6 years I've not seen R1, and there have been T4B and
very
2.
unlikely.
So it's really odd. And the other thing is that, as this was mentioned, that proficient MMR, probably this is not an approach you would use. The complete regression as well as you should not be using this in proficient MMR is what I feel. And the survivals also are not different. That's why I brought in Foxtrot. So coming to the paper which was discussed in detail, this is just a snapshot of the 3 major highlights which I could see. Quick poll among my panelists, Amish sir, Viraj, and Purvish sir. Based on this is just a snapshot. Where have you seen a waterfall like this? 1, no recurrences after 2 years. I agree that the primary endpoint was 3-year DFS, but if they have not started dropping at 2 years, how many will drop at 3 years? No delay in surgery. Only one patient was, had myositis. The other one within 10 weeks was operated. Purely based on this snapshot, how many of you would say this is practice changing? A show of hands is good enough.
I say it is practice changing.
I agree.
Okay, that's great. Shivanti ma'am? Yes. I'm going to point out if people say no. So, Purvish sir? Okay, Viraj obviously said it. Bapna sir?
I think I'll go with the recent interview of Mariam Shalabi, where she categorically said that
wait for 3
wait till
years.
all the patients have a follow-up of 3 years.
Yeah.
So Bapna sir, that was, I think, in a public forum, I think you have to be statistically correct also. But as Anand said, trust me, I'm not joking. It's a true thing. I had to search the definition of a waterfall graph yesterday, because you see the curve like this, or you see the S-shaped, or you see like this. Where do you see like this?
Amish sir, I think what Bapna sir was saying is, there's no harm in waiting a little more. That's all.
Just
And
1 year
I
more.
think,
Just 1 year more.
It's just 12 months
ASCO
more.
2025 will give us the correct answer.
I don't agree, but yes, everybody is entitled. I feel we should not be waiting beyond 2 years, and 2 years is good enough for T4N plus disease.
Okay.
The first author is not convinced. You are convincing all of us.
No, we need some dissent. So, I agree with you, sir.
That's
My
true.
dissent will really come from that one line in the paper where they mentioned that 14 patients actually had positive lymph nodes. Now, I don't know how that 14 lymph node positivity translates to.
I'll come to that. I agree with you. That line struck me also. But I found that line on the third reading. So you have a fair point. So
out of these 14, I think 4 only received the adjuvant chemo.
Correct.
So that is true, but my point is, how can you call it 98% major patch CR, major CR or whatever, if you're having 14 patients out of 110 patients having, lymph node positive? So are they like saying that lymph node little positive is still major patch CR?
Less than 10% viable tumors, na, Vamshi?
98%, they have said response.
Correct.
No, 98% major response. 98%.
No, the numbers are this.
That means
the numbers are this: 90% major response, 68% complete response. I think those are the big numbers that we need to remember, which is still not seen anywhere else. But that's what we look at. So my primary question, and this was the only problem I had with this paper, is that one, the investigators actually need to be lauded. They wanted to take high-risk patients and they modified their trial design. That's pretty good. They wanted this thing to succeed in T4 tumors, which is fair. But especially in MSI high tumors, we often know that nodal disease may not be nodal disease. It's an exuberant immune reaction. And this comes back to all your points. So it may not be disease. And staging is incorrect in 10 to 25% of these tumors, right? So why not take a call after upfront surgery? Why? 25 to 30% of these patients, and this was mentioned by Viraj, may not need any treatment at all. They could be T3N0 low risk, right? So your thoughts on that, and I'll start with Vamshi.
So I think, the challenge is it is easier to do a small study, look at PAT-CR and get your approvals rather than do an adjuvant immuno and then wait for 5 years to get a DFS or a PFS.
I'm not saying adjuvant immuno. I am not saying adjuvant immuno.
You operate upfront. The only way you are going to add any immuno is by adjuvant treatment. And there you run into the problem of, are you going to give 6 months immunoadjuvant?
No.
Are you going to give 1 year?
The question is 25 to 30% will not need anything.
Correct. That's exactly why I'm saying. So you asked, why not operate upfront? So the reason why you won't operate upfront is because you cannot prove it easily that there's an immuno advantage in a MSI high patient.
Yes. Stage 3 adjuvant immunotherapy trial is ongoing since 2019.
Yeah, Atomic is ongoing, I think.
So it's easier to do.
No, I'm not talking of adjuvant at all. We know the nature of DMMR tumors. Right. We know how radiology does not correlate very well with, what the stage is. Why not operate? That was the first thing that struck me. I mean, Shivanti, please.
I completely agree with you.
I think
patient identification is going to be the challenge. I think radiology alone will not do. You need to bring in your ctDNA. You need to bring in some other marker to tell you this is the high volume disease. Ma'am.
Yeah.
I think eliminating the surgery. The field is moving towards eliminating surgery. That is the goal. And I think that's what you are proving by bringing in surgery. And actually the bigger question, Anant, for you, I think you're coming up with that question, is whether or not you would offer surgery to these patients. So I think that's where they're homing in.
Yeah, that's all of you have the advantage of getting my slides at 1 o'clock yesterday night.
Anant, can I make a comment?
Yeah, Nilesh sir.
So if you look back at the 3 neoadjuvant chemotherapy trials in colon cancer, you have the optical, which was negative, you have the Prodigy 22, which was negative, and the Foxtrot, which was a positive trial. And the Foxtrot was shown to be a positive trial also because there was an extremely well-trained radiological assessment for the staging, which was not there in the Prodigy trial, and almost 35% of patients in the Prodigy trial in the control arm actually never required chemotherapy. So it's a similar situation in the sense that it's possible that a significant proportion of these patients would have never required any adjuvant or any immunotherapy, and that risk of over-treatment is always there.
Yeah. Fair. Yeah, I mean, I think that's what brings us back to what everyone's been saying, that, that radiological assessment, which is our gold standard, probably is not the best here. So
I think
Yes,
radiology will also take its own time, like the kind of efforts Gina Brown has put in rectal cancer radiology. Somebody will definitely take up this challenge and will come up with the protocol for the colon radiology also. It's
Sure.
just now, nobody has paid much attention as much as we have put attention on rectal cancer. We should be thankful to Gina Brown, the kind of guidelines that she has laid up.
Sure. I agree. This was again addressed in the earlier discussion. In rectal cancers, we know that largely we are coming around to 6 months of immuno, and then stop. Do you think this is adequate? 2 doses of Nivo and 1 dose of AP, Vamshi? Or do you think they could have gone forward and said, let's give a longer duration?
See, I think as long as you're looking at PATSIA, this seems to be enough. We have seen the same thing in lung. You had 2 cycles.
That is in retrospect, right? Now that you've got 90%, you're saying that.
I'm saying in lung also you had a similar study with just 2 cycles of nivolumab, and that shows as good a response as giving 4 to 8 cycles. So similarly here, I think when you're looking for just a highly selected MSI high subgroup, I think all trials have used a small duration when you're going in for a surgery. So the Neoprism used 3 pembro. This has used 2 nivo. The Cinti used, I think, 2 or 3 again. I don't think anyone is using the 6 months neoadjuvant and all, unless you want to avoid surgery radiation like you did in Dostali study. So I think
would most people agree with this approach of a shorter duration? That's what I wanted to know. Dr. Rajkumar, would you agree with this?
Neoadjuvant is always a shorter duration. That we have seen practically from patients who are put on neoadjuvant. There are real progressors on neoadjuvant. So I will always vote for a shorter duration of neoadjuvant. There's always a danger of progression in a neoadjuvant.
I think Anant, why they went for smaller? Probably because their first primary endpoint was safety.
Yes.
They didn't want to lose out, or they didn't want to prove that longer duration, and if the operable becomes inoperable, and that's why probably. But otherwise, I agree with you. It's a very bold move, and scientifically.
No, I think what I mean, and it's a very stringent safety endpoint. If you go beyond 2 weeks, they said you did not achieve your endpoint. It's very strict. So they were keeping to patient safety as well, I think. So which is pretty good, fair enough. Safety and 3-year DFS. Is this an acceptable endpoint for you, or do you want another primary endpoint of a study? Nilesh, sir?
So, now in retrospect, given the impressive results, most of us would be convinced that safety and a 3-year DFS would be a reasonable endpoint for this. But otherwise, probably an overall survival benefit is something that I'll be looking for.
Okay, that I will pick that. I'll come back to you on that point later. Okay.
Can I make a point on that, Anant?
Yeah, Viraj, please.
So the 3-year DFS, if we go back to the Mosaic study, is a landmark or an endpoint which correlates with overall survival in colorectal cancers in any meta-analysis you see. So it's one of the few cancers where a 3-year or a 5-year DFS correlates with your survival. And hence, I think so 3-year DFS was a reasonable endpoint.
Yeah,
and
I think
a surrogate marker for overall survival.
Yeah, I think the point here is that it's a curative intent, and you want all your bases covered, which is why I think Dr. Nilesh was saying that OS would be better. But your point of 3-year DFS being a surrogate is fair enough. I mean, I agree with you. Again, this is something that we have covered, and this was asked by Amish sir earlier. 1/3 of patients approximately had a follow-up of 3 years or more. Do you still want to wait, or would patients in your clinic be getting this from tomorrow? Any one of you? Shivanti, ma'am?
Sorry, I got a call. I missed the question.
Sure. So the follow-up is only 2 years. The primary endpoint is 3-year DFS. So do you think this is enough for you to start using this data tomorrow, or would you say I want a 3-year DFS before adopting it?
So I'm one of the fast adapters.
Is it just me? I can't hear.
No, I don't think we can hear her.
Oh, okay.
She's probably got a bad connection.
Yeah. Okay. Vamshi, what about you?
Today I've seen a patient,
except for Fox, that's
yeah. So Anant, today I've seen a patient who is a 43-year-old lady with a large tumor, and I was so tempted to ask them to wait till we get the MSI and tell them that, look, you are a patient who will probably you will benefit. And I couldn't do it for a logistic reason because they have done the biopsy somewhere outside. The report will come after 3 days, and so on and so forth, which is a practical problem. But I was very tempted, since especially I've read this just yesterday. So it is going to be adopted. And I think if a patient comes who is educated, well aware, there's no harm in asking them to wait for 1 month, give them the neoadjuvant, and then go for a surgery. I think it's fine. I would do it. I don't think
you
there's
would go with it.
I
So, Dr.
won't go
Bapna?
for every patient. Let me put it this way. I will not go for every radiological T3 or T4. I would reserve it where there's a big disease, again, where you know that possibly this is going to help you. So that's how I.
So that's 70% of the patients in the trial.
Correct.
T3, T4, N plus. So, Dr.
So maybe
Bapna,
not in
would you
T3
wait?
because my radiologist is not going to sit and report each individual serosal thickness, serosal involvement. It's not going to happen in the radiology.
It doesn't happen anyway.
So, Anant, as contrast to Dr. Seventhil Lime, I am a late adapter, and I generally would like to see the complete 3-year follow-up. And again, advantage is that by then that time we will have generic Nivolumab also.
I'm coming to the single agent one also, sir.
I just wanted to make a quick 30-second point. I think the bigger question will be whether we offer surgery to these people or not. I think
we should not be very hard pressed for surgery as any kind of endpoint in colon cancer, because it is not giving to give any kind of comorbidity to the patient, and these all will be colostomy free patients, unlike rectal cancer. So we shouldn't be too much hard pressed for this endpoint.
Also on that point, the radiological assessment of response is extremely poor. So how would you decide who to and who not to?
I think that is true. I mean, I think a lot of our discussions have hinged on this radiological thingy, and I don't think we have an answer to that. What I think will give us answers is if we have something like in rectal cancers where you say DRE, CEA, SCOPE, and then if you were Viraj, you would do ctDNA as well. So
sensitive biomarkers like ctDNA are the need of the hour, especially when making a decision. And I'm surprised that they did not factor it in both the trials, neither in this one nor in the SURSEX study.
Yeah, I also think that people are. I think so. ctDNA by Natera is approved by FDA, so they use it, and this was told to us. So I guess the next few trials will definitely include it, I think, because we don't have good radiological or other criteria. Yeah, Mr. You wanted to say something.
So just wanted to ask if those who are going to adopt this particular changing paper, will they also go away with adjuvant chemotherapy, or till the time we have a 3-year data, you give 2 doses of immunotherapy, but you end up giving adjuvant chemo also, mix of both the worlds. What would all the panelists do?
Amish sir, assuming you had a stage 2 deficient MMR patient, right? Let's say not high risk or intermediate low risk as per ESMO, I would be averse to giving that patient chemo. Right?
No,
I mean, a lot of us would.
T4N plus disease.
No, I'm coming to that.
Yes,
I'm coming to that. And here, 90% of them are having almost no disease. So, a quick show of hands, I think that's a good question. How many of you with a 90% response would still give 3 months of chemo in a patient who was T4 initially? So,
till the final results are available, I would give. adjuvant
Nilesh,
chemotherapy.
so that's 2 people. Viraj, I know, will say no. Dr. Rajkumar says no.
No.
Dr. Purvish says no. So I think it's kind of tending towards observation, and I'm happy I'm in that group. Fair enough. Right. So I think this was answered. Would you want a phase 3 RCT in comparison to chemo? I would not. And I think this is the way forward.
Doesn't make any sense.
Yeah, completely agree with you, sir. I think it doesn't.
It won't be
What
ethically
about,
any ethics committee.
yeah, now it won't. I agree with you. What about having a phase 3 study where surgery is done first? Any thoughts on that?
I will vote for that. In comparison with surgery versus a neoadjuvant approach, I vote for that
So
because
at least I'm happy that I have one person who says, you know, he might think of it. Thank you. Anyone else?
No,
Anyone
Anant,
else?
what purpose will upfront surgery serve?
Okay. So this comes back to what I had said earlier, that 30% of my patients will not need any further treatment.
And how will you select the 70% that will need the further treatment? How will you select that?
No, let's say I have something that's T4N1 on my scan. I operate that patient, and DMMR tumors are known to have exuberant lymph node aggregates. The final HPR is T3N0. I'm not going to give him anything. So it was just a thought. I mean, this was
Anant,
something. Yeah,
Anant,
yes, sir.
So the against that of surgery first is, if you see right from the era of immunotherapy when it has started, if you see the adjuvant immunotherapy trials, we are still struggling to find a subset which benefits with adjuvant. You take it kidney, you take it lung, you take any disease. The volume of the disease is directly proportional to the immunoenvironment, milieu, and response to immunotherapy. So for adjuvant treatment, as Nilesh said, that you'll have to wait for 3 to 5 years to even find out the cohort of the patient who are going to benefit. So I think rather than surgery upfront, we have to identify more ways to identify the patients who will go for neoadjuvant rather than.
I completely agree with you, sir. That was just a thought in the sense as a, alternate option. I completely agree.
Very good thought. Very good thought. And the point that you're trying to make here is, how do we make the application of immunotherapy more nuanced and not overtreat patients?
Yeah, that was the whole thought process.
And I think this is a pendulum that has swung to the other side, where all these patients, by definition, by default, are getting immunotherapy. What Amish said is what the field is going to look like next, where nuanced approach of application of immunotherapy should happen. And that's why when people, there was a question, phase 3. I think the phase 3 has to build on the phase 2, which is immunotherapy has to be there, and then how
look at other options.
More nuanced.
Anant, can I just make a quick comment? In this setting that you mentioned upfront surgery, say for example, the patient turns out to have a T4N2. This patient's results with adjuvant chemotherapy would not exceed 70-75%.
Agreed.
And this is a patient who would have got an excellent response with neoadjuvant immunotherapy, and therefore I would think that's an advantage.
Yeah, fair enough.
That group of patients we still don't know are not going to have a relapse in this study. We have 26 months.
Exactly, of course. We don't know.
What I think that level you still need to see. And again, in this trial, the two T4N2s are all based on radiology. They're not based on again. We come back to radiology.
Yeah. So
I think there is a trial using atezolizumab in the adjuvant setting.
Atomic, I think. Yeah. So if you can't give Nivo EP, what would you do for these patients, Bapna sir? Or I'm going to bring Shraddha in here because she's our surgeon in chief here. I mean, how comfortable are you in saying that if I can't give immuno to such patients, would you be okay giving chemo and then operating, or just operate upfront?
So as I said, I want to look at what the extent of resection and the attended morbidity it would be. A straightforward right colon with probably a duodenal wedge or an additional organ, or maybe even a bulky disease extending to the abdominal wall is okay. But if it's going to entail adding a PD upfront, then maybe I'm a little skeptical. Okay, maybe or on the side or not, or maybe favor and give some kind of neoadjuvant and then see. It may not lessen my magnitude of surgery. It may or may not lessen, but at least I know that when that patient has, I mean, we go in again, that patient has earned that surgery. And also when we operate these, and if it is a multivisceral resection and you end up doing a PD, all these anastomosis are high risk because the pancreas is soft, the duct is small. And if the patient lands up with some complication, then again you are delaying chemotherapy. So that would be the logic.
Fair enough.
To it.
Fair enough. Quick answers, Viraj. The side effects. Are you okay with this? Surprisingly low, surprisingly high, as expected.
So the question remains unanswered, Anant. If the patient cannot afford Nevo EP, then what to do?
I would go with surgery. Quick vote, surgery upfront.
Yes. Yes.
Yeah, I
Yeah,
think
obviously.
most of us.
So unless it's an upfront inoperable case where I would still prefer using a single agent.
I'm saying resectable.
Resectable, no role of
yeah.
So, Anant, the Foxtrot showed 7% responses in DMMR. So
Yeah.
surgery
So, agreed.
Chemos are not going to work.
Yeah. So,
Anant,
Viraj,
you shouldn't have voted for that because you did a study of 40 versus full dose and you seeing zero difference of Nevo.
I'm coming to that, Viraj.
So,
I'm being nice.
So in that,
I'm being nice. Hang on.
So I would still give this patient surgery upfront. I would give 40 Nevo or 20.
Okay. Quick take on side effects, Viraj. You're okay with this?
EP, no, EP is dangerous, and that's why I don't like dual.
No, but in this study,
they got lucky, Anant. Okay.
Oh, okay.
I just want to make a point here. You know, if you look at Nevo EP and across trials, the grade 3-4 toxicities with Nevo EP are actually quite low. If it's been there for the last decade and more since the West has understood the combination. And I think we really need to, so first we need to get lucky. As Viraj said, first we need to get lucky because he had a patient where he was unlucky. I had a patient on a Nevo EP study, single dose, death on study. But if we get lucky and that thing does not happen, it's all about managing the toxicity of the CTLA4. And we have to be all out there to look at any patient. And a single dose, especially in this particular dosage, much less toxicity than what you are fearful of.
Yeah, our traditional teaching was, sorry.
One patient had myositis till 33 weeks in the study.
Yeah, sure.
So,
no, so what? So
happen.
when we used to give dual immuno earlier, our traditional teaching was EP is tough. But I think once 1 milligram per kg reduction in number of doses has come, I think, it's better. I think what Shraddha had earlier said on surgery-related adverse events, she was pretty clear. I'm not going to touch radiology again. I think we are not there to answer that question, and Vamshi's already smiling. So this is, one of the questions I think, if you cannot give EP, would you be comfortable giving only one of the available immune checkpoint inhibitors? Nilesh sir, I'll start with you. Quick points from at least 2-3 of you.
So this brings us to the question of dual IO versus a single IO. And I would not risk an upfront operable patient with a situation where I don't have data to use. But like I mentioned, in a patient who's got a T4B or something like that, I might consider using a single agent drug. We know that dostarlimab has excellent responses both in colon as well as in rectal. But I would not use it as a convention in all patients.
Dr. Rajkumar, you don't have access to EP.
Yeah,
one of the immunos is
I will go with the single agent, either the PEM or the Neo.
Okay, I'm not going to ask Viraj because he will say yes. So I think a lot of us, I would err towards giving immuno in this patient, even if it was single agent, Pembro or Nivo is what I would do. This is some of the
Anant, I wanted to mention very quickly. I'm sure you're aware of the Dream GI project, the registry, the national registry. And in that, the largest utilization was of pembrolizumab in a large percentage of patients, and the responses were still very high. And one last mention about the outcome endpoints. So yes, the outcome endpoints that you have outlined, the paper had kept as the primary endpoint, but everybody does talk about the overall response rate, even though that was a secondary endpoint. So somewhere that has become a very important endpoint for all these patients where you are, surgery is there, but you are thinking at the back of your mind to eliminate the surgery. And that's why the responses are being followed and are actually being utilized as a surrogate for survival, which has to play out still. So these 2 points I just wanted.
Sure. I think this is that one set of tumors where I'll go beyond traditional teaching and say that response is a good surrogate. Most other scenarios, I would not say that, but I think DMMR is a class. Agree with that. This is some of the exome sequencing data. One thing I really liked was that there was no correlation of TMB with response.
Yes.
I'm so tired of that thing. TMB, and there was no response, no correlation. And I just wanted to highlight that. Another thing was that, beta 2 mutations in the MSI high metastatic was a negative prognostic indicator. Here, you had PAT-CR in 70%. To me, that was what was striking in terms of this one. I think I've run out of time. Amish sir had gently messaged me saying that, how much more. So I won't take the discussion into rectal cancers, but I'd like to thank the panel for their involvement in the discussion and the organizers for inviting us.
Thank you,
Anant, before you sign off, since you had mentioned about the rectal in this slide, it would be very quick if you can in 2 minutes summarize what you wanted to highlight in this rectum also. I think we will learn out of your experience.
Okay. So the main thing I think is the lower rectal cancers, which is where, we are wanting immuno to work, because wait and watch is now a possibility in close to 50 to 70% of patients if you use the OPERA approach, and immuno is going to go beyond that. The other thing is that in colon cancers, quality of life is not so much of an issue as in rectal cancers. Large syndrome is tough. So if you can get away with surgery, that's a really good endpoint in rectal cancers. Surveillance in rectal cancers is very well defined. Response assessment is very well defined. That is not the case in colon cancers. And 6 months, there was some doubts on in colon cancers, 2 doses, 3 doses. I think most people are agreeable to 6 months of immuno and ongoing responses beyond that, which was pointed out by Viraj as well. So those were 2 or 3 points that I would like to highlight. And yeah, thank you. Thank you so much.
Thank you so much, Anant. Over to Parikh, sir.
Thank you very much, Anant, and all the panelists. I think this has been one of the OBTOs where there has been such intense discussions, as well as, a different spectrum of what they would do in real life practice, in spite of having such wonderful data. But I think instead of me talking about it, let us hear the expert comments by Dr. T. Raja. It was a pleasure to meet him a couple of days ago in Ahmedabad. And I now eagerly wait to hear what he has to say about this publication. Dr. Raja is a senior medical oncologist from Apollo, Chennai.
Thank you, sir, for having me here. Amazing panel discussion and amazing interview. Can you allow me to share my slides, sir?
Sure, sir.
I hope you're able to see my slides.
Yes, sir.
Yeah, thank you. So once again, amazing, session as usual. Amish, we all, we a big thanks for continuing this, series. Every day it's fantastic, and every day you are setting the bar higher and higher. And after such a great interview, Amish and Viraj and then Anant panel and such enlightened panelists, what am I going to add? I'll try to see what I can make some sense given the job. Thank you for that. And this is an amazing paper, as you have already alluded to. And so I'm going to look at this paper by asking few questions as a clinician. These are the questions. My questions, first question is, what really happened here, with the, with a little bit of recycling what has been said, that this is the original study design as presented in ESMO 2022. You went through all these things. And then the first and foremost thing that struck us, and what both Anant and Viraj pointed out, is that all underwent surgery, and the 98% of the patient went through that timely surgery. That was the most important thing, because that's a safety primary endpoint. And then comes the next issue, the pathological response. We see that the major pathological response is 95%, and the complete pathological response is 67%. And this amazing waterfall plot, which we all saw, this is major pathologic 95%, as presented in ESMO 2022. And the other thing that was brought about is that as to how the pathological responses were different between the Lynch and non-Lynch sporadic tumor. And in Lynch syndrome, the pathologic response was higher in 78%, and sporadic tumor is 58%. All these things are important. And as was shown in the updated NEJM 2024 paper, these are the path responses. So this is what has happened, and that's why it has created such an impact. So that's why we are looking at this paper. So then the next question is, why did this happen, and how can I explain this? And that's what I'm trying to put a context to why this all came about. We just want to take you back to some basics. In neoadjuvant efforts, we are all aware it's happening forever. And in breast, whenever there is something targetable, and whenever there is something, be it HER2-driven disease in breast cancer, or TNBC, we have already shown that some neoadjuvant assets, PAT-CRs, and then as was already shown, the Foxtrot, in this particular subset where we are interested, dMMR colon is only 7%. So this brings a perspective of neoadjuvant chemotherapy or even targeted therapy. That's what we had as a background. And the Foxtrot trial was already much discussed. The pathological responses were observed in only 7% of DMR. This is very important when we want to answer those clinical questions, whether we will choose neoadjuvant chemotherapy for all our colon cancer or not. This will be our, as of benchmark to decide. Then comes the paradigm shift of using the neoadjuvant immunotherapy. The effort, again, is not new. If you look at the lung cancer, Checkmate 816, 24% with nivolumab and chemotherapy, and Keynote 522 in breast cancer, pembrolizumab, it is around 64%. And then Keynote 689, Upuluri's paper on head and neck squamous cell cancer, pembrolizumab is 44%. And then the dostarlimab paper, MSKCC study, dMMR rectum, 100%. And again, bladder cancer, Nivo-Ipi, that is the Mobocor study, the path response rates are 43%. This again, why this is important is the whole shift of immunotherapy, if at all we have to use, whether neoadjuvant is the best way to do for many reasons. You see the path response, you can assess the response, and then whether this is the best way to do immunotherapy in appropriate patients. That's what this kind of correlation brings up. That's a question still to be answered. Then who brought this to us, and why is it so important to talk about that person? Dr. Chalabi. We have already talked about Dr. Chalabi, and this is Dr. Chalabi as she has gone on over the years. This is before 2020 when she was, and then this is when she presented in ESMO 2022, and this is her ASCO 2024 paper. Why would I present it here is that how she pursued this idea, and therefore she was recognized by Nature Medicine in April 2020. So that's important. That's why I'm bringing. And then her whole idea of niche, in which she clearly showed the binary that in pMMR the response is different, and dMMR the response is different. That's what was appreciated by Nature Medicine. That's what I think. And then she went on to do the NICHE 2 study, in which we have seen this stunning waterfall plots. This partly answers Vamsi's asked questions. Here, the path responses are captured for both the tumor and also for the lymph nodes, and therefore some of the patients may still have some lymph node positivities, and that will beg the question: what will we do for those patients? Adjuvant, we'll come to that. But these stunning waterfall plots are now called as Chalabi plots. So that's what is the oncology world giving us a respect to her. And why is it important? There are a lot of hidden things that she did. That's why she is lauded, I would believe. If you look at this Zoo's paper on what is the difference in the DMMR and PMMR, it is just not the MSI. There are so many other things that are happening. Even in MSI high patients, 35% of them are not going to show either no or little benefit with immunotherapy. Why? Because there are so many other things happening. So let's quickly look at predictive responses to immunotherapy as best biomarkers. We are all very, very aware PD-L1, and then MSI, it shows high mutational burden, TMB, more neoantigens. There are clear explanations, but we also learned that there are other predictive responses indicator, like the T cell receptor clonality, the diversity and higher TCR clonality, and interferon alpha, interferon gamma, and then JAK1 and 2 and beta 2 microglobulin genes alterations. So why this is important? Because she has factored it in early on. She has tissue plasma and she has got peripheral blood monocytes also captured all along the design. That's I think she was already thinking about all these things, and she has partly answered many of these questions, which is sometimes missed out in well-done studies. And this is what she added. These are the additional results of Dr. Chalabi, as was already captured by Dr. Anant, that there is a whole exome sequencing in 107 patients, which clearly showed that TMB is not associated with PATH CR rates. And she has also shown that higher percentage of PATH CR in BRAF 600 wild-type patients and higher in RAS mutations than RAS wild-type. That's a kind of a paradox. And again, in patients who have a beta 2 microglobulin gene altered, there is a higher complete response. So these are all hypothesis generating or already established facts on which you would then start really teasing your patients and trying to choose your patients. And how is this happened, and how is this going to impact our further options? I'm just trying to take you away a little bit from this study. And this is Neoadjuvant in the metastatic setting in the first line. As was already mentioned, checkmate 8HW. This is what's happening in the landscape. This is the PFS. And if you see the early on, the curves, there is no initial dip. That's what Dr. Chalabi answered, that CTLA-4 inhibition is doing, that the early dip is prevented by CTLA-4 inhibitor. And therefore, she herself has answered the question in several interviews that whether CTLA-4 is really needed as in this design or not. So that leaves us some margin that you can use a single agent nivolumab. And this is Keynote 177 in the first line. And there is another study known as the SAMCO Prodige. This is avelumab in second line. These are all DMMR patients in the second line, in patients for some reasons who have not received immunotherapy in the first line. We'll just look at these curves. This is the Prodige SAMCO curves, and this is the Keynote 177 curves. So we try to intake this curve and show that what Keynote 177 can do in first line and what the Ipi-Nivo can do in first line. And if you miss out avelumab, what it can do in the second line. Again, Nivo Ipi checkmate 142 in the second line. So all these things tell us that in DMMR patient, it is very important now to consider some form of immunotherapy, whichever you can probably access. And then you can even push the limits. And this is another important study that's coming up. And this study is another model on which many other studies are going to be talked about in the Nivo EP plus LAC3 in esophageal and gastroesophageal junctions. So why this is important is this opens up the question whether we have already walked into an era of talking about chemo-free treatment in DMMR colorectal patients, and by extension, whether all GI cancer patients who has DMMR at any line, neoadjuvant, first line, and second line, even in all GI cancer, that's where this the most important example what Dr. Chalabi thinks is esophagus and OG junction diseases, and that's where we are, and that's why, as Viraj pointed out, parachute study, and this is as paradigm shift as what we saw in the TKA studies with either CML or the early studies in lung cancer. But of course, this is still not yet data strong or still not yet tested in the adjuvant setting. So that's the take home. And the landscape has been really expanded. DMMR, colorectal, or in any GI cancer, please think about some form of immune checkpoint inhibitors at some point. That's the broader message, I think. Thank you so much.
Thank you very much, Dr. Raja. While dissecting this publication, we have understood what was happening in the patients on the trial. But you have given the chabi to Chalabi's mind. And you have actually, identified what is the background, how this trial design was ideal for this situation. And not only that, but what else is in the pipeline in the future from the same patients with different amounts of data that is being collected. And finally, you correlated that with some of the other trials, and that was absolutely fantastic. I think this is how we hope that OBTO experts give their concluding comments at the end. And now,
I agree with Parikh sir. Sir, your bar of expert comment is rising each day so much कि हम लोग को नीचे से ऊपर आने में भी टाइम लगने वाला है. It is amazing, sir. It is amazing.
So I'm going to conclude here. Thank all the faculty. Our next OBTO is going to be in August on 13th, which is the second Tuesday at 7 p.m. And now I hand over back to Amish for his comments on today's OBTO.
Thank you so much, sir. I think today, it was amazing. We all learned a lot. This is a new era, a lot of learning. And I think I learned a lot today. And I thank each and everyone who are here for supporting the learning more. As we go forward, we will have more and more papers like this to discuss. And I sincerely again thank all of you, and please keep supporting the science behind the OBTO as you all have been doing. Thank you so much for this.
Thank you.
Thank you.